Morning, Krishni. I can confirm that we are now live.
Thank you very much, Tom, and morning everybody, and welcome to our board, Integrated Care Board meeting in public for NHS Herefordshire and Worcestershire, and delighted to welcome any members of the public who may be observing us today. We do have a couple of apologies. We've got an apology from Stephen Coleman, who from Worcester Acute, and also Paul Robinson from Worcestershire County Council, and participants Russell Hardy and Mark Yates from our two trust chairs. But we do have Francis, so welcome Francis for joining us today. I also want to just take a moment because I don't want to leave it till the end in case I forget, just to say on behalf of the board an enormous thank you to Jane Ives. I think, Jane, a little birdie told me that this is your last meeting. So I really just wanted to say what an important and enormous contribution you've made, not just to the board, but to the community we serve, and the trust, obviously, that you are the key leader in. You know, thank you for everything you've done and your support to our board and, you know, the community in general. So I just wanted to take that opportunity to recognise your contribution, Jane. Thank you.
Thank you, Krishni. It's been an absolute pleasure working in the ICB. Actually, it's been a really interesting time, hasn't it, as we move into a new phase. But thank you very much.
Pleasure. Okay, so we have some questions from the public, but we can come on to that in a moment. Let's just deal with our usual governance items. So just double check that. Are there any declarations of interest in relation to items on the agenda? Nigel, please.
Thanks, Krishni. Yeah, I'm chair of Tourist Healthcare, so that is involved in the out-of-hours bid. So I think that should just be recognised. That is in the CEO's report, and also part of WBC PCN, which was part of the women's menopause pilot, just for completeness.
Thank you, Nigel. Really helpful to note. I think we're not making any decisions, so no problem with you obviously being involved in any discussions at the moment on any of those things. But thank you for highlighting that. I think that's helpful. Governance log, including board forward plan. Hannah, anything that you need to highlight?
There isn't really. We do have a spotlight on urgent care at the next meetings, just for information, but there is nothing on the action log, Chair.
Okay, thank you. And we did, I think I did check with Hannah beforehand. I believe we're correct. So Hannah, unless you tell me otherwise, I think we are. So we'll note that as well. So we have the minutes of the previous meeting held on the 16th of July. Can I just check with colleagues that they're happy to approve those minutes? Excellent, thank you very much. Okay, that's all our meeting management items. We move on to our patient and public voice, and we do have questions from the public. A three-part question received from Simon Nichols. So I'll read all three parts out if that's okay, but if anyone needs me to repeat that, then do let me know. I think Mary is going to respond to them in any case. The first part is, does the board have any knowledge or experience of the Community Health and Wellbeing Workers programme run by the National Association of Primary Care? The second element is, are there any plans or would the board consider trialling this initiative? And the third part is, would the board consider an organisation that centralised signposting support locally across the public health and voluntary community and social enterprise sector a valuable asset? Mary, if you need me to repeat any of that, please do shout, but otherwise I'll hand over to you for a response, please.
Okay, thank you, Chair, and thank you for the question from the member of the public. So yes, the ICB and indeed our primary care networks are aware of the community health and wellbeing worker concept. We are in early days, but we are communicating it out to primary care probably constantly over the next few months to make sure they are fully aware of it. There's already been some communication. We are, though, looking forward to further exploring how we localise this within the PCNs, and our way of doing this. The plans that we're putting this, we're going to align this to our neighbourhood health programme. So the idea of building on that community assets and connections, and I have to say the team took me through some of what's out there currently, and I was personally shocked at what is available out there. There is a wealth of support that I don't think all our practitioners know about. And working with those local residents who know and understand their communities better than anybody is going to be embedded into our neighbourhood health services programme. So we have commenced mapping all those community assets. I think it's going to take us a little while to do that because of the significance of the size of it. And we'll further work with the district councils and the voluntary sector colleagues in our ICS to achieve this, and then through our neighbourhood team health programme decide how we embed this in practice. The way, on the final bit of the question, the signposting. So we're in quite a fortunate position. So we already fund the local PCNs for a single point of access called the Joy app. It's an app which I looked at a couple of weeks ago. It brings all of the resources together that we've currently got or know about in one place. So our social prescribers in primary care and access to those neighbourhood health services should be aware of what is out there and who they can signpost individuals to. And I believe there's even a link to back into the EMS, the GP service, to help to track all of that. I think it's some of it is embedded, some of it we need to continue to embed further out there in practice. But we've already got, on that last bit of the question, that valuable asset in our system, which is that Joy app, which we'll continue to promote. So I think it's quite an exciting innovation for the neighbourhood health programme, and should use the resources more effectively that are out there than we probably currently do.
Thank you very much, Mary. Really comprehensive, really, I think, worthwhile question to receive. So thank you to Simon, and really important prompt around, the link to neighbourhood health service development, which I think is obviously the feature that we are focused on through the 10-year plan. Roy?
Yeah, thanks. And just to add to that, in our primary care network, we're actively exploring the community health workers. So we're working with the National Association of Primary Care. We had a meeting with them yesterday, and one of our GPs has got some trailblazer funding to support that. And obviously we'll share the learning back with the other networks as well. So definitely really strong evidence behind that approach.
Excellent. Thank you, Roy. Really helpful. So thank you for that. We will then move on to the patient story. So Kath, I think it's over to you for the patient story today.
Thank you very much, Chair, and good morning, everybody. Just to let you know that the patient story has been anonymised to protect patient confidentiality, and this patient story this morning follows Kate, a 54-year-old woman, along her journey to a total knee replacement. Kate had a long-standing history of knee problems and underwent a total knee replacement at Spire Hospital as part of a waiting list initiative with the NHS in May 2025. Her knee issues began over 15 years earlier following an accident that resulted in bilateral meniscal tears. Over the subsequent decade, Kate managed worsening pain herself. After 3 episodes of not being able to walk, including being unable to put her foot to the floor, her GP referred her for specialist assessment. Imaging revealed osteoarthritis in both knees, which was bone on bone in her right knee. Due to the advanced condition of her right knee, a total knee replacement surgery was advised. Kate waited approximately 18 months for surgery. Her journey was delayed due to a separate health issue, inducible laryngeal obstruction, which is a vocal cord dysfunction, which meant that Kate had to come off the waiting list for surgery whilst receiving treatment for this, including speech and language therapy. Kate was able to join the list again for surgery in December 2024. During the pre-operative period, she attended several appointments to prepare and plan for recovery. This included face-to-face physiotherapy sessions to manage expectations and plan for post-operative recovery. Kate was also advised to lose weight if possible prior to surgery to optimise outcomes, and was successful in losing 2 stone prior to the surgery. The surgery was carried out as planned in May 2025. It was carried out under a spinal block without sedation, an initiative by her anaesthetist due to her previous throat condition, which Kate agreed to. This approach allowed her to be alert immediately post-surgery, facilitating early mobilisation. Although initially planned for a 2-night stay, she was discharged in less than 24 hours due to excellent recovery. Although the majority of her experience was positive, Kate was not discharged initially with enough pain relief, meaning she did need to follow up the hospital shortly after discharge to arrange and collect more medication. Although full rehabilitation takes 6 to 12 months, Kate describes her experience as good and that she had a great result. She has gone on to lose a further 2 stone, helped by being able to be more mobile following surgery. Kate remains under the care of the same team and is motivated to protecting her remaining left knee for as long as possible, cycling and swimming to help this. Continuity of care and access to a consistent physiotherapist before and after surgery was highly valued, and the established rapport contributed significantly to her positive experience. Some of the learning points from this patient's story highlight how pre- and post-operative physiotherapy in total knee replacements can enhance patient confidence and recovery. It is also a great example of how spinal block anaesthesia can facilitate earlier mobilisation and reduce complications for patients with comorbidities. It also highlights how comprehensive pre-operative preparation and patient education supports better surgical outcomes. Overall, the patient described her experience as highly positive, highlighting both the quality of care and the support that she received throughout her journey. Thank you very much, Chair.
Thank you, Kath. And I think what struck me about that story is, whilst it was, broadly positive, there's a lot of learning about what went well and what was valued by the patient, and what was effective in improving the outcome for the patient, which I think is really helpful to hear, because sometimes, naturally we focus on things that have gone wrong sometimes and what we can learn from what's gone wrong. But I think here there are some really good examples of things that went well that actually are repeatable. So thank you, Kath, really interesting. Does anyone want to make any comments or ask any questions about that? No? Okay, thank you very much. So obviously that, sorry, Will, did you want to comment?
I think it also just highlights the importance of prevention in this space and the importance of the lifestyle aspects of this, the regular activity, keeping active, the loss of weight and the importance of that, and how we support patients in that space very much falls back onto what we're talking about from the 10-year plan.
Yeah, thank you, Will, absolutely. And of course, the story does link very clearly to our spotlight section today, which is on elective and diagnostic care. So we will come on to that shortly. So if there are no further comments or questions, we thank you very much, Kath, for sharing the story, and for Kate to share her story with us. And move on to Simon for his Chief Executive's report, please.
Thank you, Krishna. Good morning, everybody. So hopefully you've all had a chance to read the report. Just as usual, I'll happily draw out a few highlights, then happy to answer any questions about anything else within the report. So the first section talks about the latest around ICB reset. So this morning I'm sat in Rugby Hospital in an office because I'm attending the Coventry and Warwickshire ICB board this afternoon. You'll see from the report that Krishna has been appointed as the chair of both ICBs and the ICB cluster, an appointment that will take effect from the 1st of October. As of today, I'm seconded to be the chief executive of Coventry and Warwickshire ICB as well, pending national confirmation of appointments, which might come one day at some point in the coming weeks, but we'll see. other than that, we're on track. We've got a lot of work to do, and my reflections from doing this job for a few weeks now, it's 2 jobs at the moment, so we are going to have to do a lot of work to turn the cluster management and leadership approach into a thing, because it will be unmanageable otherwise for people involved. But we've got a clear plan as to how we can do that. Some complications, I think, regarding Treasury support for redundancy funding, but we're doing the best we can to navigate around that, as are other ICBs actually across the country. So the report covers the headlines from that. Just in terms of operating plan headlines, which are across page 2 and 3, I think we've got some work to do, but we aren't in a bad place. And I think for a lot of the indicators, actually the first 4 or 5 months of the year, which is where the data covers, have been pretty successful, really. So we're obviously now very focused on the winter period to come. It's really important that we continue to hold the position, that we continue to improve in a couple of areas where there's a bit of work to do. But as a whole, for the middle of September, the performance overview is a reasonably positive one, I think, relative to other years when we've been in a similar place. Just wanted to pull out on page 4, so congratulations to Nigel and colleagues from Taurus, who were successful as part of the Neighbourhood Health Implementation Pioneer Programme. We'll be meeting with Claire Fuller and the national team to work out precisely what that means, but also to emphasise to everybody, there were 4 bids went forward from Herefordshire and Worcestershire. The Herefordshire bid is the one that is on the programme, but actually we'll be looking to work with all the other 3 bidders as well. The progress, the momentum, the pace of effort and energy that's going to go into neighbourhood health isn't going to change, really, even for those who aren't on that pioneering programme. So we're looking to share that learning that Nigel and colleagues get, but to roll out all of that across the system as well. And that will be a big feature, I suspect, of the next year or 2 or 3 as we try and make further improvements in neighbourhood health in our system. Just also worth pointing out, page 6, so our 4th annual point prevalence audit study takes place today. So David and the team have put the arrangements in place. It'll be useful to understand trends, see how some of the improvement activity that we put into tackling some of the issues identified last year, to see how that has resonated, the impact that's had, and obviously we'll look to bring the analysis and the results back to the board once we know those. We're also remiss of me to mention not to mention the GP patient survey. So again, we have this conversation about this time every year when it comes out. We always do very well in Herefordshire and Worcestershire relative to other ICB areas. This year we've probably done the best we've ever done. So Roy, Nigel and colleagues, patients in Herefordshire and Worcestershire, according to the National GP Patient Survey, were more satisfied with their experience of general practice locally than in any other systems in the country. So we can't get any better than that. It's a really important part of how this health and care system works. It will remain a really important part of that, and it's really important we kind of all rally round and support colleagues to continue to offer the very best service around, really. And things like the patient survey are never it's always a bit subjective, because people say, well, my experience was different and I had problems with this, and that's absolutely right, but it's the best measure we have of comparing our position relative to other systems. So, well done, and thank you to colleagues for all of the efforts to improve general practice patient experience, because that definitely is reflected in the survey. But yeah, Krishni, I'll stop there probably, and happy to take any questions or anything else.
Thank you, Simon. As ever, there's a lot of content in the report, so do come in. Obviously, some of it we may want to pick up with other more detailed reviews, particularly where it relates to quality, etc. But very happy to start the conversation here. So let's bring colleagues in. So first of all, Rachel, please.
Thank you, Simon. A really comprehensive report as usual. I just thought there's some really interesting areas of strategy in there. The health inequalities and sorry, I've just lost sight of that, the housing and health now, and the work and health strategy I was particularly interested in. I was just wondering how we're going to, you know, roll those all into something that kind of links with our 3-year forward-looking strategy as an ICB, because there's going to be some really good stuff in there, isn't there, for us and our population. And I was just wondering how we'd go about doing that, and any thoughts you've got on that would be really helpful.
Yeah, that's a good reflection, Rachel, and you're right to point out we're doing some really good work in each of those areas, and what's been interesting is to see the impact it's having. So in each of those areas, we all knew they were a good idea, we all knew they were good initiatives, but now we're kind of 12, 18, 24 months down the road with some of it. You can start to see the impact. I think all of these elements will remain key focuses for ICBs moving forward. As we start to work across a cluster, there'll be some elements of this where we can share some best practice, and I'm sure there's some really good practice in Coventry and Warwickshire. It's been interesting to watch the government strategy to some of it as well. So I think the economic benefits of the work on health inequalities are starting to come out again in policy. The work around the health impacts of supporting people to get back to work, it's here to stay. The Work Well programme actually has got some really very good tangible outcomes in supporting people back into work, which obviously economically is supporting a whole load of other government policy drivers, isn't it? So each of these areas are here to stay. We're just going to have to reflect a little bit, I think, on how we most effectively take them forward across the cluster, whilst not losing some of the progress we've made. So David and team have done a great job in each of these areas. They all feature as part of every bit of our strategy. We're just going to need to make sure, and I'd expect the board to kind of challenge us to make sure they are appropriately referenced in things moving forward as well. But you're right to point out we're making some really good impacts in all of these areas.
Thank you, Rachel, for the question, and Simon for the response. I think Rachel makes a really important point, because these are the building blocks, aren't they? We're talking about the wider determinants here rather than healthcare services per se. The importance of work to health and the importance of housing to health. So it's very much a part of our future radar, really, and part of our current as well, but increasingly important, rightly, as you say, Simon. So great to see all that work actually coming together and captured in the way that it has been. Aman, please.
Thank you, Krishni. I just kind of wanted to make the point that, this is a really positive report, and considering, Simon said where we've been in previous years, and I just wanted to kind of highlight the point that given the instability we've got with the ICB reset, that it's really positive to see that the patients are still being put first, and that's not having an impact on our community. So I just wanted to kind of make that point. I think it was really important to kind of highlight that. I had a couple of questions, Simon. One was, are we expecting to see any more industrial action? And I know you were able to kind of cope with that quite well from the report. But I had another question, which isn't related to your report, but I just felt it was important to ask. It's something that I'm experiencing in the workplace at the minute. Just, whether you felt any impact from recent protests and stuff in terms of the workforce, whether, how they're feeling, whether there's, just really wanted to understand whether there has been any impact. Not that I want to conflate the issue, but just if there has been, if there's anything that we're doing to support colleagues, given the diversity of our workforce.
Yeah, thanks, Aman, and I'm happy to start on that last question. I was at an event yesterday and Wes Streeting actually was speaking, and he gave a really strong message around the political support for an absolutely zero tolerance approach to any racist behaviour for any of our staff. I have had a couple of emails, to be honest with you, Aman, since the weekend from people who were a little bit worried. We will take the opportunity to provide as much reinforcement and support as we can for people. We will not tolerate racism towards our staff. We want our staff to feel safe. We want our staff to feel part of something special, actually, and they are part of something special when they're working for the National Health Service. So you're right to point out it is something we've got to keep a really close eye on. We've had periods like this a bit in recent years, haven't we, where we've had to rally round and support staff. It looks, doesn't it, like the national mood is also again heading that way. So really important that we do all we can locally. But actually, I was quite pleased with Wes Streeting's commitment to this. In fact, he got almost a standing ovation of applause. Ellen was there. It was really quite stark how committed he was to supporting that messaging. So really, really good, and we must do that locally. Just on your other couple of points, so industrial action, none has yet been confirmed, but I think it would be appropriate to say that there's a more than reasonable chance of further industrial action. Clearly, when it comes to recovery plans and keeping momentum, particularly around waiting list reduction and elective care progress, so much of that is contingent on the workforce being available every day and maximising capacity. There was even an impact from the few days industrial action we had last month. You can see that in the figures. We can't afford many more months of that. So obviously it's certainly within our interests and the interests of patients for all of these people to kind of come to appropriate pay deals that people can live with, which avoid industrial action. It would be incredibly risky were the NHS to head into another period of prolonged industrial action across different professional groups, and obviously that's where we've been before, where we've had doctors, junior doctors, paramedics, nurses, general practice. Lots of people have felt they had no choice but to take action. That has a real impact on the quality and access for patients, and we want to avoid that, don't we? But yeah, I would absolutely, your first pointer as well around there is uncertainty, but it's my job and it's everyone's job on the call to keep people's focus on the day job, and we've tried to keep that front and centre of our messaging throughout the change process. That's difficult. It's difficult for people because there's a lot of uncertainty, and I think the uncertainty around the ICB changes is probably going to go on quite a bit longer than we had initially thought was the case. I think we're probably in for another year at least of transition. Our job as leaders is to provide as much reassurance, as much support, as much openness around communications to allow people the right time and space to focus on the day job. And yeah, I would pay credit for people for the work during the first half of this year, because it is reflected in where we are in lots of performance indicators. We just need to keep that going for the second half of the year. But yeah, thank you for the questions.
Thank you very much, Simon. And maybe, Mark, when you come on to the finances, it might be helpful just to, I think it was good to see that we'd managed through the period in terms of impact on patients, but I did wonder whether we'd seen any impact in terms of specifically on finances, and I don't know whether it's visible yet, but it might be useful just to understand what that is when we talk about our financial performance later. Vicky, please.
Thank you very much. Simon, I guess for me that seeing the patient survey results is fantastic, but it'd be helpful if you could just draw out on the dental access, because there's been so much work that has been done across the ICS that it would be, from a public point of view, really helpful to emphasise that point.
Yeah, thanks, Vicky. You can see that on page 8 of the report. So 2 areas of dental commissioning work, one around the urgent dental care. That's a national initiative, which we think is probably a little bit less relevant because we think we've got quite good urgent access. But Charmaine and the team have done some good work with the dental providers on that. But probably most importantly is the additional activity that we've been able to commission. So particularly in Herefordshire, that, if we're honest, probably had amongst the worst dental access in the country 2.5 years ago when we started on our journey with dental commissioning. Now we're kind of heading much towards average, which of course isn't the end destination, but it's a big improvement on having from being bottom of the league. We're heading towards mid-table. The 2 new contracts, the 2 new practices in Herefordshire are both now fully mobilised, and most importantly, they're both delivering nearly 100% of their commissioned activity. The big problem with dental contracts is we offer money, we offer activity, and typically practices will only deliver 50 to 75% of the activity that's offered, and then we get money back at the end of the year, which of course isn't really a lot of use in driving dental access for patients. So we're on the right track. We're really lucky in having a very experienced and excellent dental commissioning team led by Charmaine. So we've got a lot of plans for areas where we think we can further improve dental access, where there are kind of hotspots of poor access. Charmaine and the team have got a really clear idea and a really clear plan. We just need to work through matching the kind of financing of that new commissioning activity, but that's all built in to the medium and longer term financial plans. But yeah, thanks for pointing out it is a success story, and it's a success story that we want to build on further.
Brilliant. Thank you, Simon.
Thank you very much. And I think in terms of the patient survey, it specifically mentions that despite the challenges around access to NHS dental services, 70% of patients describe their overall experience of dental services as good, which is actually remarkably positive, and again has shown improvement. So that's great. Thank you. Jane, please.
Thank you. You said at the beginning, I'm very quickly approaching the end of my service, and so I've been spending a bit of time looking back and reflecting on some things. I wanted to just talk a bit about urgent care, because it absolutely is the challenge we face, because with everything else that we're doing, if we don't make improvements to urgent care, it gets in the way of everything else. And so I pulled out some data from when I first started in Herefordshire in 2016 and where we are now. And before I start sort of giving some of that, there has been no population increase at all. We serve the same number of people now. Clearly, they're 9 years older, but we serve the same population now as we did in 2016. Our A&E attendances are 51% higher. Our emergency admissions are 50% higher. And we've converted a lot into same-day emergency care. So probably our emergency admissions, if we count it in old money, are probably 70% higher. So those numbers are absolutely huge. We're also doing 100% more elective activity than we used to do. But obviously, we're dealing with a backlog. So there's some mitigation for that. But my reflection is there's lots of things that we can do, but I do question whether we should be doing lots of those things. And Will's got a workshop that he's leading this afternoon about how we look at risk across our pathways. And I think we've all got, certainly I've got several, experience of older, particularly relatives, where lots and lots of things have been done, and you question the value to the individual of the things that we do, but those numbers are enormous. So in 2016 we admitted 22,000 emergency admissions, and last year that was 32,000. As I say, with a conversion of 50% are now seen in ESTEC. Those are just the admissions. So those numbers are huge, and if we don't get on top and get a grip of our emergency pathways and where we care for people, we're not going to make the progress that we want to make. So I just wanted to add that reflection, really, because I think it does get in the way of all the other things that we want to do.
Thank you, Jane, and those figures are really quite thought-provoking, let's say, but I think we've certainly touched on the risk, I suppose, of sort of utilising a lot of activity or driving lots of activity. And some of what I think, I worry that some of what we do, and I'm not talking about us specifically, but actually it's not helpful to incentivize activity for us to deliver lots and lots of activity, and which actually doesn't improve the patient's outcomes. And I think that, one of the things, weirdly, I said at a workshop on Monday was, I do think it would be helpful for us to be thinking nationally about making sure things like NOF, segmentation, or the oversight metrics, all of those things actually are not reinforcing the need to drive activity versus improving outcomes, because I think there is just something about being selective about the outcomes that are going to make the difference to the patient, and making sure that our systems drive that really. And you know, I don't know the actual answer to it, but I think it's those sorts of things I think we need to be thinking about. So it's really good that we're having those conversations, because I think, Jane, in fact, in part of the point prevalence audit work that we've done before, we've had those conversations as well, haven't we, when we've been reflecting on that data. So it's really important to highlight. Did you want to come back in, Jane?
Someone once said, and I can't remember who it is now before I quote them, but our system, is perfectly designed to give the outcomes that we're getting, and so we have to change our system if we're going to change that around, because at the moment it's delivering what we've designed it to do. So we really have got to redesign it.
Yeah. Thank you, Jane. Ellen, please.
Thanks, Chair. So I had a couple of things. So I think thank you for the report. It was really comprehensive, and I think probably others have reflected it, but I just wanted to also add how pleased we are that we will see continuity. I think we can't underestimate the impact of the ICB change process on colleagues on this call. So just wanted to congratulate you, Krishni, and Simon on your appointments. I know Simon's obviously interim for now, and to say thank you for all that you're doing to support the teams at this time. So that was the first thing. I also wanted to, because it's been mentioned by others, I just wanted to pick up on the issue around the flags and the increase in racist incidents. So I just wanted to say that we have in the Community Trust seen a measurable and significant increase in racist incidents towards our staff, which is incredibly disappointing and upsetting. So I've already done 2 sort of all staff, I do a weekly broadcast to my teams to acknowledge the issue, to remind teams of the support offers that we have in place, which do include removing care from patients who do not show, who effectively do not show the respect our staff deserve. Now, sometimes that's complex around mental health acute services, but in general terms, that is our policy, and we've reminded staff that we absolutely will not tolerate any racism or abuse of our staff, and these are the support mechanisms we have in place, as well as some of the tools we have around things like active bystander training. So I think it is really worrying, and a number of our staff are, as well as the formal mechanisms through our networks as well, reporting the sense of disquiet and unease that they feel. We've similarly had some of our patients in community mental health services phoning to express that they feel fearful and anxious at this time, including some of the really vulnerable in our society, such as people living with a learning disability. So I think it's important we acknowledge that, and we can see real evidence of a significant and measurable increase at this time. So as a community provider, I just wanted to share that and some of the things we're doing. And then the final thing, this is quite a diverse little eclectic thick group of things I wanted to raise, was just a really small but practical positive one. So in your report, Simon, you talked about the work on stroke pathway improvement. So just wanted to note as well that, because it wasn't in the update, that we now have a joint appointment of consultant posts between ourselves and Worcester Acute Hospital, so working across the acute and community wards. And we've also appointed a shared programme manager to work on that improvement in the pathways as well, reporting in to the System Stroke Board. So we're working jointly on that to try and take forward the improvement at pace. So I just wanted to note that for the update. Thank you.
Ellen, thank you. I think, I think we would all support your sentiments that you've shared, and it may be useful, Katie. I don't know whether it's a conversation you've had across the people directors, but if there's anything we need to do from a system point of view that would be helpful, I think it's worth perhaps just thinking about it, but I really welcome the strong leadership that colleagues are demonstrating on this, because I'm sure it is disquieting for people. And given the diversity of our workforce across the NHS, it will always, we need to make sure it feels a very safe place for people to be and work and be themselves. And actually, I just wanted to thank you for sharing the example of a joint appointment, because for me, that's when integrated care actually begins to sort of feel real, because there are practical things that people are doing together that actually make integration possible. So really helpful to note that. Thank you, and welcome that update. Okay, David, please.
Thanks, Krishni. Yeah, just a quick comment really, Simon, on the neighbourhood health delivery. So it's a kind of congratulations, firstly, that we've done the work on that delivery framework and it's attracting regional and national interest. And I think that reflects really well on colleagues. And that led me towards being really surprised that there wasn't already, and clearly there wasn't already, a national ICB prioritisation framework. It's the kind of thing that I would have expected to be done nationally earlier, and clearly it wasn't, of course, but I did want to ask for assurance that we are not always automatically doing stuff by ourselves, because of course it takes up a lot of resource, but that we are also looking across the region and nationally to make sure that if there is work that could be usefully used or reused, that we're still happy to do that, as well as creating our own where necessary.
Yeah, happy to come back on that. I mean, David, you're right, and of course we're always looking around. The team will tell you that there's no monopoly on good ideas. We can usually find a good idea from somewhere else and adapt it. I guess my only reflection is that there hasn't been a national prioritisation framework, and I think the politicians would say quite deliberately, because they would expect local areas to be making their own prioritisation decisions based on their own particular set of needs, so that they want us to embrace some of the difference and be a bit different. I think that moving forward you will probably see more consistency, actually, certainly as we become more strategic commissioners. We'll want more consistency in kind of prioritisation and policy across wider areas. So we will get that. I mean, there is a postcode lottery in parts of the NHS at the moment, because some ICBs, some CCGs, some PCTs, and whoever came before them, they would have particular policies for certain treatments or access thresholds that were different to their neighbours, and they took active decisions because of various factors. That's allowed. So we have got to just balance that, reflecting local difference in need with prioritisation. And we are a national health service, aren't we? But I suspect for the next period we're definitely on a journey to more consistency and less difference, I would think.
Thank you.
Thank you very much. I'll take a couple more comments because we're a little bit behind time, but usually we do catch up our time, so I'm not particularly concerned about that. Nigel?
Thanks, Krishni. Yeah, I wanted to just personally thank Jane for her contribution and her huge advocacy for Herefordshire as a whole, not just for the Trust, but for her leadership of One Herefordshire, because I think her input has been massively significant. So thank you, Jane. The other point I wanted to make was a stat that came out yesterday in the national meeting that, and this relates to some of Jane's comments, was that nationally we spend £500 million, or 9% of A&E attendances are for attendances where there is no significant treatment or investigation, and that would fund 10 million GP appointments. So for me, that is quite a significant stat, because comes back to, are we doing stuff that we should be doing differently? And part of that comes down to the challenge for the neighbourhood health programme, I guess, to work things differently. But I wonder whether that should be a metric we should look at locally, because actually we're spending a lot of money then for an expensive resource which is not strictly necessary.
Nigel, thank you. Can anyone respond to that in terms of the ability to collect that data? Mary, are you able to comment on that?
Thank you. Yes, and Nigel, our ED audit showed something similar, to be honest. I think we'd have to do a detailed data analysis, but it did show a similar picture, and the ability to direct people away from the ED is a challenge, and particularly those that live around EDs. But I do agree it's the work of the neighbourhood health and how we redesign access that's going to be vitally important for this.
Thank you, Mary. So it does need ongoing focus, I think, is what we're all agreeing, isn't it? Simon Adams, please.
Yeah, thank you, Krishni. I just want to make 3 points. The first is, I think, to put on record our thanks to particularly the GPs for the work they're doing. And it's really pleased to see that the survey's borne out our view that we continually present at national conferences where GPs tend to get a bit of a hammering, I say, where we talk about how good our network, our service is. So a thank you for that, and to see the data actually proves it as well. The second point links back to Jane's point, I think, about, and perhaps the most recent point, about urgent care. And it's about the extent to which the ambulance service is actually buying into what you're trying to achieve from a layperson's perspective. And if I just give you a very short patient story, my mother's in a care home. She's 96. My most recent contact with WMUS is when they went to see her at the care. They were called to the care home to check her over, and they then ring me and say, should we take her to hospital? And I could give you other examples of where they've done that. And you kind of come as a layperson to think that they see their job as taking people to hospital rather than looking at alternative strategies and taking risk. So I wonder whether with the ICB reforms, whether there's an opportunity for WMUS, because they're always the people, apart from urgent emergency care meetings, who are missing from around the table. So I wonder if there's an opportunity to buy them into this as a member in a bigger way. And then finally, just to mention the National Oversight Framework. And I would say that Healthwatch and patients are really concerned that that doesn't undermine the work that is going on in terms of the pursuit of league table performance. And we're also not sure it'll actually give the patients the choice, or inform patients in a way in which they'll be able to make choices, because it won't necessarily reflect a lot of the good work that's going on in Worcestershire, for example, which I could quote, which you wouldn't pull out of as a patient, you wouldn't pull out of the National Oversight Framework.
Thank you very much. Thanks, Simon. Mary, do you want to come in on the, well, Mary and Will possibly, but Mary first, maybe on the WMUS point?
Yeah, I'm sure Will's going to say the same thing, but firstly, just some assurance that WMUS are a very active member of our ICS Urgent Care Board, and we have regular discussions with our link director in WMUS. And indeed, that story you've told, Simon, with our ED audits again and recent case studies are showing exactly the same issue. For the first time ever, WMUS have asked us to help them go out and train some of their new staff to explain our system, explain our single point of accesses. But it's clear in the very frail and elderly, we need to change the way of working, I think, as Jane said earlier, to make sure we give them the best care in the most appropriate place, which isn't in an ED, it's in their own home. So we are working actively with WMUS on that one.
Thank you. Will, do you want to come in as well?
Yeah, just to say, so the question raised, Simon, I think it's a really important one, is that we work in an environment where people try and do what's best for the patients, but try and balance that against their professional risk. And they don't always do that perfectly. And that's exactly the focus we're going to have on this afternoon when we do the risk workshop. Try and make things really patient-centered and try to make decisions in the best interest of the patients, even when risk is there. WMUS is absolutely represented at that meeting and is going to be there and part of that discussion. So we will be including them in that, and they are really bought into this as a way to work forward. And actually, if you look at their conveyance rate over the last decade, it's gone down dramatically. So something is working in that space.
Thank you, Will. And it sounds like this workshop that you're having this afternoon we'll try to get to the heart of some of that, albeit I think it's important to recognise that changing things like this is cultural, isn't it, to some extent? So there is a sort of training and building people's confidence to take the right decisions is not a quick fix, but important nevertheless that we're doing the work on that. So and Mary, as you said, I think the audits have highlighted this, and the discussion about call before you convey has been ongoing, hasn't it? So helpful to know. Obviously, we're stimulating a lot of discussion as a result of this. I've got a couple more points, but I will probably have to stop there after this. So Roy and then Sarah. So Roy first, please.
Thanks. Really quickly, just to really agree with Simon on that, and I think that it's not just the organisations. I think there is a wider cultural piece. Actually, there's a lot of people who believe that going to hospital is the best place for you, and actually the evidence is completely the opposite, particularly as you get older and more frail, and the default should be, how can we keep this person at home? And I think collectively we need to do more in that place to reassure families, because I think sometimes families are put under pressure to say, are you saying you don't want your relatives to go to hospital? Whereas it should be, we're going to do what we can to keep this person at home, and we're all okay with that. I think there's a really subtle but important message that we need to get out to all of us, really, all organisations. Actually, being in hospital as you get more old and frail is actually a bad thing to happen, and should be something that we just is a last resort, whereas at the minute, particularly with WMS, I would agree, it feels like it's the sort of default. So I think there's work to do there.
Thank you, Roy. Sarah, did you want to come in?
Well, I can't say it better than Roy has said it, but also the only additional thing to that, and we are working on this really well in the system, we've seen papers brought on this, is respect forms. One thing that we can all do to support our relatives if ever we are unwell is, whatever age you are, really make your wishes known. Respect forms are there as well, so actually that really helps relatives if you've laid out your stall before as to what you would like when you get older, or if you become unwell. So I think that just helps, and I think we're all saying the same thing, aren't we, really, that really interesting discussions we're going to have about our hospitals and hospital performance, but home as the place to stay, if care can be provided there, is hugely important.
Always reminds me, Roy will correct me if I get this wrong, but I think it's hospitals are for repair and health is made at home. Is that right, Roy? Is that the one?
Perfect. Yes, thank you.
And I've always loved that. I think it's the title of a book that somebody recommended to me. I've never read it, but I just love the title, so I use it a lot because I think it captures to me everything that we need to convey to people. But I think the challenge for us collectively is to help our population understand it, which I think is what everybody said, and that's not easy. And I, on a personal level, I mean, I remember, I have a doctor in the family, so when my mum was frail and towards sort of at the back end of her life, if I can describe it that way, we had a lot of incidents, but he was really clear. Hospital is not the place for her, and actually, therefore, we kept her at home as much as we could, and it helped, I think, because every time she went to hospital, she came back worse. In reality, in a lot of different ways, albeit repaired in some other ways. So it is a lesson, I think, a difficult lesson, because it's not an easy thing to convey. So there's just something about how we communicate that, and perhaps we need all our partners to think about that, and we need a sort of probably there's something about the example of Home for Lunch and the campaign that we've used there, whether there's some ways in which we can communicate these sort of quite difficult messages. That they're quite complex, aren't they? So how do we convey that, I think, is just really important for us to consider. But thank you, everybody. A really comprehensive discussion about a whole range of things. And particularly, I know in Simon's report, he wanted us to note, as we touched on at the beginning, the the refreshed strategies which are associated with the report, the health inequalities, the work and health strategy in particular, but also to note the outcome of the ICB annual assessment. But a lot of content in that report and a lot of points raised, which I think are really important sort of discussions and context for the rest of today's meeting. So thank you. So we move on then to the spotlight, please, on elective and diagnostics. Thank you.
Thank you, Krishni. Colleagues, this spotlight provides detail of the work of our ICS Elective Cancer and Diagnostic Board and the very strong now operational work and the improvements within our trust providing elective and diagnostic services, which is the focus for today. The board has had, quite a few priorities, but it's mainly about improving access and the outcomes and timely access for patients to the care they need in the right place, optimising the capacity that we've got and that we commission and provide in our system, really work on our productivity, particularly post-pandemic, and redesigning care pathways where needed to modernise them, to future-proof them and to make them less fragile within our services. So a lot of the work has been a real joint collaboration between primary care, our NHS providers and the independent sector, but has been heavily influenced by the Getting It Right First Time. I know I mentioned this a lot, but the Getting It Right First Time programme has really helped in the elective and diagnostic space. And as difficult as it's been, the tiering process that we've had as well has helped to jumpstart some of the improvements that we've needed. So I'd just like you to take you through the current position of our elective and diagnostics in our ICS, some high levels of the transformation work that we're doing, and then some of the quality and financial and health inequalities aspects that are associated with you. You can see it's quite a complex programme, elective and diagnostics. So happy to be stopped at any time for questions and for clarity, if that's okay. So this time, I look back this time last year and what we'd said to the board, and we were grappling with 104-week waits and 78-week waits and in a quite challenged position. And it's really pleasing to notice now that we've eradicated both those 104 and 78-week waits. They were unfortunate, they've now gone. And we have seen some diagnostic wait improvements as well, which is really good to see. So in this year, we're focusing on reducing waits to less than 52 weeks, which is still too long. It doesn't get us to our 18 weeks that we need as a national standard. But it is pleasing to note that within some of our specialties, we are at that 18 weeks wait, and that is good to see. But we need to get it across the board. So this year we've also got less reliance on the National Elective Recovery Fund that we obviously all aware of from last year, and the additional independent sector capacity that we were constantly chasing. Instead, we're focusing that ERF recovery fund in a targeted way to develop more sustainable ways of working. Focusing on productivity, really good waiting list validation, and we're doing excellently on that at the moment in our acute providers, and strengthening that mutual aid across the providers and the redesign that we've talked about. We've been set nationally quite a challenge though in the Reforming Elective Care for Patients plan that was published earlier this year, that by March 29 we'll be back at an RTT, which is that 18-week standard for referral to treatment, by March at 92%. So that is quite a challenge for our system, given what Jane said earlier about the increase in demand, the expectations of the public. That is going to be a challenge for us, but we're currently looking at, through many of our programmes, what we need to do between now and then to get us to that position. And that's joint working, that's working with the independent sector and a range of other initiatives. The performance, as you can see at the bottom of page 2, is measured in many different ways, operating plan ways, but also we're regionally benchmarked against us and national standards. So won't go through it obviously, but there are some good signs of improvement. I mean, particularly I think, nice to see is the outpatients improvement around specialist advice and guidance, missed appointments and waiting list validation. We benchmark extremely well, and it's pleasing we're having other areas contacting us to see how we're doing it, which is from this time last year is a really good position to be in. So the current areas of focus, demand optimisation is a key part of the strategy for elective and diagnostics care. So making sure that we only send the most appropriate patients to the right setting to receive that specialist consultant support that they need. So we're doing that in a number of ways. We have the well-known common conditions documents across primary care that have been worked up extensively in our system, helping and supporting primary care and others to deliver care outside of hospital where possible. We have the straight to test approaches for diagnostics. Yes, that's putting a lot of pressure on diagnostics, but if it's reducing the need for an outpatient's appointment, that's helpful as well. Advice and guidance, I think, has been a real success in our ICS. Again, primary care have really supported us. It's been a few years now, but it's embedded well in our system. And you can see we do very well in responding to advice and guidance and actually turning those patients away from the consultant-led care back to primary care with the appropriate support that they need. And we are benchmarking extremely well on that. I think what's pleasing to see in each place, there's primary, secondary care interface groups that are really driving this locally in a very operational way, looking at the key aspects in that new national plan, but enhancing them really in our local area to work on the relationships between primary and secondary care and how we are communicating and making things as effective and efficient as possible. And that's, some of that has been recognised nationally, some of the work of our primary secondary care interface groups in recent guidance given to other areas, which is really pleasing to see. Obviously, from a commissioning perspective, we're looking at how we can optimise demand as well, and we're making how we can make those services sustainable. So I've given as an example halfway down on page 4 of cataract procedures, which we have, as Mark often says to me, how many more patients need cataract operations, Mary? The demand has gone up significantly. But we have introduced, alongside the rest of the region, a minimum waiting time for cataract procedures, ensuring consistency across our providers, prioritising patients with the greatest clinical need, and reducing that unwanted variation that slipped into our system post-COVID. And that's it's designed, it's just starting to help us to manage the demand in our system. And we're also working on evidence-based interventions. Again, we did this pre-COVID to make sure that we're only undertaking procedures in our system that are actually clinically appropriate and in line with national guidance. So there's a whole piece of work on managing demand in our outside of hospital to reduce the need for particularly elective services. Diagnostics, on the other hand, is a particular challenge for us in our system and is a growing challenge. I mean, I was shocked myself to see that approximately 70% of healthcare decisions are made on a diagnostic test. I think that's definitely grown over the years in healthcare. So we need to ensure we've got sufficient capacity and for tests and investigations to meet that demand. We've been fortunate enough to get 2 community diagnostic centres, one established in Kidderminster, and unless Jane tells me differently, in the next couple of weeks we'll be opening the one in Herefordshire. I won't go through all the details. You can see what we're delivering in those community diagnostic centres, and it is really helping us to get that urgent access for diagnostics and to redesign to get some one-stop shops, which will be great to get the one-stop approach to diagnostics, advice, treatment and discharge would be very helpful. So we are actually being asked to prepare another business case for the potential of a further community diagnostic centre if national resources allow. And looking forward and projecting for the future, we're going to need more diagnostics, but we're also going to need to transform our diagnostics. And I'm not an expert, but AI can do an awful lot in diagnostics. We've seen some of the work that can happen, and it does look very powerful in helping us going forward. So we need to transform as well as put extra resource in to support us. And there's some examples there you can see of some of the work that's already happened in diagnostics using digital tools. Outpatient productivity has definitely been a success, and I think if we reflect back, for those of us who were here 2 years ago, it was one of our key areas of concern. So I think it's definitely congratulations to the providers on how they've handled that outpatients reform, and you can see where we're benchmarking, particularly well on missed appointments. We've done excellently on that. Patient initiation follow-up, we're doing fairly well. There's need to improve there further, but our validation of our waiting list at constantly achieving over 96% is one of the best in the region, if not the best in the region, and that is being congratulated at the moment. The GIRFT programme has supported this. We're now covering 17 specialties. We started off with 6 a couple of years ago. We're now with 17, and we're planning to add more to those specialties. And those specialty groups, which are later described in the paper, and the GIRFT that's being driven through those specialty forums is really powerful. It's getting the clinicians, the operational teams together across our ICS to drive that improvement. And Professor Tim Briggs is regularly meets with us to make sure we're still on track, which is good to see. One of the outpatient transformation initiatives now being delivered routinely in some of our areas is collective care approaches, and this is multidisciplinary team clinic appointments, group appointments for particularly long-term conditions, and super clinics, as we call them, high volume clinics with multiple staff in there with oversight from a senior clinician, and that's starting to make some real benefit. And we're seeing that in quite a few of our specialties at the moment, which is helping us. We've also, another example of what we're doing, we've managed to be successful in tabling funding to pilot a community model for ear examination and microsuction. So that acute to community movement, I was quite alarmed to see how much of this was happening in our acute trust a few years ago. We're moving that out to the community, and with the tests and the ability to deliver that service, and that's designed to reduce ENT and audiology demand, which is one of our key concerns in our system at the moment. And all of this together gives us that strategy for each of our specialties that helps to make us sustainable. So that's an example of that. Theatre productivity, again, I did look back a couple of years ago, and we're now delivering over 86% day case activity. And when we first met with Tim Briggs, I'd say that we were one of the most challenged in the country at this, and that's what he told me. And we've made significant improvements and at a rapid pace. So again, well done to the providers on that. We're well ahead of the regional average, and we're actually exceeding the national standards as well. Theatre utilisation, again, made improvements. Some more to do, but definitely making improvements and going in the right direction. And the focus in theatre productivity is reducing late starts in theatre and early finishes to make sure we maximise that whole session and build on the improvements that we've made to date, which is really helpful. I think using an example of a specialty, hip replacements, length of stay has come down from 4.3 days pre-COVID to 3.3 days in March this year. And knee replacements, similar improvement, and improvements in minimal access rates for patients receiving a hysterectomy for a benign condition has gone up to 79.8% and performing best in the country at 89% now, which is really pleasing to see. Again, some more improvements to make in trauma and orthopaedics, but we've come a long way in the last couple of years. We just need to continue to grow. And the trusts have put in place surgical hubs to help them to protect the elective work, and and when we have the pressures on urgent care, it's now much less rare that we have to stop elective work. In fact, in Worcester, I don't think we did it at all last year, which was really pleasing to see. We've given you examples there of the specialty forums. You can see all of the specialty forums that we now have in place that drive the GIRFT agenda and drive the transformation, some of their key achievements in their area of focus, and they've become almost the engine rooms for our ICS for delivery of this improvement, which we need to make sure we don't lose this in the transition to the new ways of working, that this is working well, and let's build on that rather than lose it. some of the examples where we focused on inequalities is the Women's Health Hub. I'm sure, I think we brought this here before. There's a National Women's Health Strategy for England 3 years ago now. And we were tasked with establishing women's health hubs to make sure that the women's inequality in care, particularly for gynecological pathways, was resolved and that the women's voices would be heard. So you can see the impact of the work programme. I won't go through all the detail there, but we've had much stronger feedback and much better outcomes and much better patient experience for women through driving this agenda. We need to do more. We need to make sure that we can continue that work, but we're starting to see some benefits of that. There are some, challenges that are being picked up through our Building Sustainable Future programme. We have, some services that have been vulnerable, fragile for quite a long time in our elective pathways. So this year we're focusing ophthalmology, haematology and dermatology. And for two of those, we're close to be coming up with a designed way of working for the future that we'll take to the Building Sustainable Future Board. And indeed, we're planning the next 4 that we want to do next year. And those 7 would cover a lot of the areas that are fragile, that give us that ability to take us to that 92% for 2029, because we need them to be resilient to be able to achieve that. Behind all of this, it's the one area of our ICS we've been so focused on the doing, we haven't got the strategy in one document that gives us that clarity for the future. So we will be developing a strategy for elective cancer and diagnostics that reflects the 10-year plan requirements, reflects what the improvements in performance that we need to make, and as I said, resolves those fragile services for us. So in the next few months you'll be seeing the outputs of that work. We have very strong patient and public feedback through our elective cancer diagnostic programme board and other routes. Healthwatch help us a lot with this, and we have good feedback from the trusts and the independent sector into that group to ensure that we get to hear the patient's voice in all of this. And one of the big things we heard recently was the NHS app could really help us with appointments, understanding when appointments are and speaking to people rather than having to phone. So that's a challenge for the NHS app if that can be sorted. We took some time as part of the Elective Cancer Diagnostic Board to look at the health inequalities. And not surprisingly, in line with a lot of national information, some of our more deprived areas in our ICS are more likely to wait longer for an appointment, wait longer to have more missed appointments. Children are a particular focus, but that's a national issue. Children not turning up for appointments, and some of our ethnic groups, there is some evidence that they come late to appointments as well. So we've now got a bit of a focus on this, and our next piece of work is what can we do through the health inequalities work to resolve some of this, particularly in our hard to reach groups and our areas of health inequalities. So we will probably be focusing that in particular areas of the ICS over the next year. That's going to be a work programme that's taken up. I've outlined one of the quality issues that we came across that was quite concerning. We had to do review and recall exercise on paediatric audiology services. All that work has now shown that the quality of those services is now assured, and the improvement plans are continuing to be rolled out. But we're much more confident that we have safe paediatric audiology services. The finance and contracts, and I might bring Mark in on this because he might want to make a comment on this, but you can see how much elective activity we delivered last year, which is a large amount of elective activity under that National Elective Recovery Fund. And we did actually achieve, on month 11 last year, we're still waiting for month 12, I believe, 128% against the 1920 baseline. So you can show, it shows the extra work and what was achieved last year in our elective pathways. This year, obviously, the funding regime has changed, which we know, and we've now got elective care indicative activity plans across all providers. So on month 2 activity, we've delivered £46 million worth of activity of care, which is with inflation is definitely an increase on to date from last year. So we're still managing to deliver a lot of care, and we can see that in our elective recovery plans. You can see, you know, we still have the independent sector provider working with us under patient choice regulations, and 50% of the 20 independent sector providers are working actively with us at the moment, mainly with ophthalmology. Is one of our biggest use of the independent sector. So that's a very quick overview of a deep dive into electives, and happy to take any questions.
Thank you, Mary. Very comprehensive. Questions or comments then, please? Nigel.
Thank you, Mary. That was. I think there's a lot in there which is really encouraging, actually, that we are starting to really make a difference and transform services. The outpatient reform, of course, is going to be absolutely critical for the NHS as a whole. If you just look at the cost of outpatient follow-ups, it exceeds the whole national spend on general practice. So that shows how much resource is tied up in outpatients activity in what is quite a traditional model. And I think some of the things that you talked through, some of those innovations, you know, the virtual engagements, the group consultations, the new ways of doing things, absolutely the right way to try and do things in a different way. I think we really have to, you know, innovate in that space enormously. I think the other factor is, of course, we've got increasing frailty and multi-morbidity in our populations, and actually the role of community multi-morbidity clinics, which might require different skills and training, is going to be key for us handling that elective type activity in a different way, and that feeds into the neighbourhood approach. But I just wanted to make sure that we were capturing that, because this doesn't always work in a purely medical model. It doesn't look down individual specialities. It looks down in a sort of a biopsychosocial model, which supports people in their homes and supports people out of hospital. So are we building that into our strategy when we're looking at how we are reforming this? Because I think welcoming all that great work which we're doing, which is predominantly around a sort of medical model structure, are we looking at the broader sort of neighbourhood piece there as well?
I could come back in, Krishna, that's very helpful. Nigel, I might ask you to our next meeting. We had the first meeting about developing a strategy a couple of weeks ago, and exactly what you say, we've done well. Our strategy needs to look to the future. It's interesting, we're cross-referencing some work that we've done on our patient transport service, and looking particularly at outpatient follow-ups without any procedure, and the frail elderly that we are bringing into hospital for outpatient follow-ups on stretchers, often with 2 or 3 people bringing them into hospital. And we're going to start to ask the question strategically, what are we achieving with bringing those patients into hospital? I've had personal experience, not myself obviously, but with family, and wondering what that achieves. And I think the idea of having that community support in whatever way we do it, reducing the burden on outpatient follow-ups, allowing the most senior clinicians to do the work that we're going to need them to do with the growing elderly population that we have, I think is really important. So exactly, we need our strategy to change that, particularly outpatients transformation from where we are now, because we'll never, I don't think any ICS system in the country will be able to manage with the future if we don't do it.
Thank you. And Mary, in some respects, I guess, you know, that so much of this was focused on recovery, wasn't it? And it's now transformation. I think that's the switch point, isn't it? Is how do we kind of change? With the journey of recovery is fantastic. It's just how do we now begin to kind of make it more sustainable, which is what building a sustainable future is all about. Thank you, Nigel. And look, I'm sure you'll look out for the invitation to that meeting to contribute. Rachel.
Yeah, thank you, Mary. I think it was a really great presentation and a really informative paper, so thank you very much for that. But what I couldn't see is with all this great work that's going on, what impact do you think this will have on the waiting list, say in 12 months' time? So have you modelled some of that through, what it means by each specialty and what impact this will have on those particular areas?
So thank you. I think it's referenced in the document too. For 52 weeks, we anticipate at the end of this financial year we will have eradicated 52-week waits. There's just a little bit of work at Wye Valley Trust on one specialty, I believe we've got to resolve. 65 weeks should be gone by October this year. So that's our aim this year. There's 3 specialties that we've got to focus on to take us further than that, which the specialty forums are working on. And as I said before, some of that will be redesigned, some of that may need extra resource to deliver it. And the 4 specialties that we're going to choose for Building Sustainable Future next year will reflect that the need to do that. I think we're aiming for 2029 for the 92% RTT. You know, I can't see us, unless some significant changes in the finances happen, being able to deliver that before 2029.
Thank you, Mary, and great question, Rachel. I mean, I did have a sort of similar question, Mary, just about the diagnostic bit of that, because I was kind of thinking, well, there's obviously a lot of development around diagnostics, and you did highlight that was an area where perhaps we weren't quite as you know, in strong a position, but obviously really positive that there is, you know, the new CDC opening in Hereford, etc. And I just wondered what we would expect that to do in terms of improving our position. So have you got any sense of that as well, or Jane has a sense of that?
I mean, there is as part of the business case and the agreement, there is some trajectories to be achieved. I think some of those are going to be challenging because the demand has continued to rise for diagnostics. And I think part of wanting that diagnostic strategy is to really, over the next 3 or 4 years, plan out what we believe are going to need in what modality for diagnostics. Put the transformation in around AI, digital, whatever we can do to reduce the demand, and then plot all that through to give us that 2029 position. We haven't completed that work yet for diagnostics.
Okay, thank you, Mary. Vicky, please.
Thank you, Mary, for the presentation. There's so much information in there. I guess my question with some of the positive initiatives and developments over the last couple of years, how we make sure that there's a consistency in outcomes for patients, whether they go down the route of the independent provider or through the NHS, because we heard the patient story, didn't we, and the very positive benchmarking that we can get from that. It's just how we make sure that we are working with the independent provider to make sure that all of the initiatives that you've outlined are delivered to get that consistency in outcomes.
Okay, thank you. So we obviously have the same approach as we do with our NHS providers through our contractual arrangements and contract and management boards and quality assurance processes through Kath's team. We haven't had any major quality issues related at all. Remembering the independent sector, it's a lot of the less complex work that the independent sector undertakes. So it's not an even playing field really. But we at the moment we've got no concerns about the independent providers that we are working with from a quality or contractual point of view.
Okay, thank you, Mary. And finally, we've got a couple of questions from Roy and then Sarah. Roy, please.
Yeah, I think Nigel made a similar point, but it's thinking about, I think we've done some good work up till now, but in the future, as we go into neighbourhood working, we need to have some quite different discussions. And I think the GIRFT agenda has been very good to get us to where we're now, but it still feels very secondary care focused. And I've gone along to a couple of the clinical forums, and actually it feels the focus is still very much on secondary care, whereas the opportunity is for us to work together in primary and secondary care, collectively share our resource in a different way. And I just think we need to make sure those conversations aren't restricted by GIRFT, because that's had its time in some ways. It's a bit, and I think we need something slightly new. And I guess the other part of that is making sure that we continue to get primary care representation in those meetings, because that's a continual challenge for us with a lack of infrastructure and that. But I think that clinical representation from primary care, I think, is the key to some very different approaches with some clinical discussions. But we need them to be different, not what we've done already.
Yeah, totally agree, Roy. We need to find a way to make that change with primary care involved in that. And I think dermatology could be one of the ways that we start that, Will, through Will's work on dermatology.
Thanks, Mary. Sarah?
Thanks. Mine was just a quick point on just to acknowledge really the breadth of that this report covers, but to pull out and to link with a comment that was made earlier about the work strategy that we have, about housing, about some of the other the wider determinants of health, and how actually you've nodded to that and linked to that, but how important it is that we acknowledge some of those complex sort of multifactorial issues in people's attendance at appointments, and how we work with partners to see sort of how we can really do true system working to improve people's health through the health delivery element of our elective strategy, but to work on some of those wider determinants. And please forgive me for being pedantic, but I would just hate any misquotes anywhere. You said when referencing sort of ethnic minority groups, you said come late to appointments, and I believe what you were referring to was present late with cancers. And so I just heard that and thought I would hate any misquotes there. So so long as I'm not misrepresenting you, we do know that people do present later with cancers, and that is a health inequality, and we want to, as you reference, work on that in the strategy. Thanks.
Thanks, Sarah. Mary?
Thank you. I mean, it wasn't really cancer I was focusing on, Sarah. It was electives, you know, that they often present with, particularly on the trauma and orthopaedic, present very late for that. So just making sure it wasn't cancers I was talking about.
Oh no, thank you, and my apologies for that, and that fits beautifully with that whole wider determinants point. Actually, there's potentially so many other issues on people's plates that health can come quite far down the line, can't it? So thanks.
Great, thank you very much. I was just going to finish off because I think we probably do want to take a short break, but I was remembering as we were talking about the improvements in theatre productivity and utilisation. It feels like ages ago now, but I quite early on in my tenure, I joined a Transformation Tuesday at Wye Valley, which I think Jane was at, and was challenging the team around colleagues on the call around theatre productivity and utilisation. So actually 2+ years down the road, actually seeing how much it's improved, that's really good to see. And of course, it was a big topic, Simon. I think when you and I first took up post, 104-week waiters were right up there on our agenda. And I've often said I spent the whole of my first 6 months understanding probably more about 104-week waiters than I'd ever had done in my life before. So I am really pleased that we've made so much progress. But I think what colleagues have highlighted is there's obviously more to do and more to change and build on, and that's why it's really important that things like building a sustainable future. And indeed, I didn't want to miss the opportunity. I think there's an appendix associated with this report on working together principles which have been developed, which again I thought really highlighted the importance of that partnership working between colleagues in primary and secondary care. So all these things are really important building blocks for what we need to continue to do, but great progress clearly has been made, and thank you to colleagues around the table who've obviously made huge efforts to drive that. So we note that report, Mary. I don't think there was anything you particularly wanted us to approve there, so it is an update and a very comprehensive one at that. So good opportunity now to have a short break, and I suggest we come back at 11:10, if that's okay, promptly to start with Mary's report on quality and delivery, please. I think we should catch up our time after that. Thanks very much. Okay, welcome back everybody. Thank you for coming back promptly. Mary, over to you for item 10, which is our system quality and delivery report. I think there's a few aspects obviously we've already talked about and through the spotlight, but I know there are plenty of other aspects in the report, so if you could highlight those, that would be great. Thank you.
Okay, thank you, Krishni. As ever, this gives you an overview of our QRD, our Quality Resources Delivery Committee. There's been some really strong performance noted in our indicators at the back of the report, particularly within dental and access to children and young people's mental health services. We've seen some improvement, which is good to see. And we're now starting to report on continuing healthcare and infection control. So we're continuing to develop our indicators across the ICS. That's just give an overview of the changes we've made. I'm just going to pick up urgent care, cancer and mental health, if that's okay, and a little bit about children's. So the urgent care performance we discussed a bit earlier, but you know, continuing to be strong on ambulance response times, and we've even seen some improvements in the 45-minute handover. Getting to 100% of patients handed over in 45 minutes is a challenge for us at the moment, particularly you know, particularly going into winter, but that's our ambition, and our recovery plans are all designed to deliver that. The biggest concern is our 4-hour standard. It remains our concern, and we are, you know, it's one of the most challenging metrics we have in emergency care, and I know both providers are continuing to put in actions and pieces of work to make that improvement, and have got trajectories in our operating plan to improve for the rest of the year, so we'll be watching that closely. As a result of the first quarter, Wye Valley Trusts were unfortunately placed into Tier 1 support, and Worcester Acute was stood down from Tier 1 to Tier 2 as a result of their improvement. I'm sure Jane will agree, pleasing to see the significant improvement Wye Valley have made since that first quarter, and we envisage they'll come out of Tier 1 quite quickly from our discussions with the regional team back into Tier 2. We've also, the winter plan has been developed. I know we've had a session on that. We had our first winter assurance visit with the region a couple of weeks ago. We've had very positive feedback. It's now all about delivery, in their words. So they're happy with the plan. It's about the delivery of the plan that we need to make sure happens. Cancer services. So some of our cancer services are performing well, some we are challenged, particularly our 31-day, our 65-day cancer weight pathway indicators are continuing to decline. We had got them fairly stable. They are declining at the moment. So they have got recovery plans in place. We've had some support from the West Midlands Cancer Alliance in the form of resource to help us to do that. And as a result, Worcestershire Acute are now in Tier 2 for cancer services, particularly around skin and urology cancer pathways, aiming to see improvements in those services. We continue, though. I think it's really pleasing to note the fecal tests that we do for potential bowel cancer. We're exceeding the national target. So the work across primary care and secondary care that we put in place a couple of years ago has been sustained and is working very well on that pathway, and it's pleasing to see. I'll go on to mental health. So mental health. So I think, you know, our strategy of eradicating out of area placements aligned to reducing the length of stay in our ICS providers is working. So our target of 53-day length of stay has been exceeded, and we're now at 48-day length of stay. So we've been able to bring the patients back in, or discharge the patients that were out of area. They're back in our area, and that's really pleasing to see. And the plan is to sustain that. I think the one area of significant challenge I'd like to the board to be aware of is our children and young people waiting to see community health services in Worcestershire. We have got, you know, that continues to grow. The long wait over 52 weeks and indeed 104 weeks continue to grow, and we're working in partnership at the moment to try and find a way through to make some impact to try and reduce particularly those long waiters. And we've got limited assurance on that at the moment, but we are working together collectively to come up with that assurance to make that change as quickly as we possibly can. And I know Kath will be happy to take any questions on the quality aspects of the report as well.
Thank you, Mary. Any comments or questions? Vicky?
Thanks, Mary. I think just a comment on the stroke indicators, which I know were discussed earlier, but just fantastic to see the indicator for patients eligible and receiving thrombolysis, because that's been quite a long time sort of in the doldrums. Is there a specific change that we've introduced that's enabled us to improve that indicator?
Yeah, indeed. I had yesterday afternoon, we had a meeting with the clinical lead about all this. Really, this is clinical leadership in practice. And we've got, you know, I mean, if you remember 3 or 4 years ago, we had, I think, 1 consultant. We've now got about 6 or 7 consultants at Worcester Acute with a very strong clinical lead. And the region asking him to go around the region and show to others what he's doing, which, you know, that's a significant change, I know, in our position. The door to needle time, that's the patients getting to the thrombolysis time, has improved as well, particularly at Worcester Acute. So we've seen a significant change through that clinical leadership that he's provided.
Thank you very much, Mary. David, please.
Thanks, Krishna. Thanks, Mary. Again, a comprehensive report, of course. As you pointed out at the end, of course, the children, young people area is the area which I think it probably concerns us all most of all, because we see the future there and need to focus on that. Can you tell us a little bit more about what steps we're taking and what we see that trajectory being?
Okay, thank you. So our strategy at the moment is threefold, really. It's asking our provider to validate their waiting list. We talked about validation in the acutes and how strong that is now. We need the same in our community waiting list as well. That's the first strategy. The second part is we have commissioned 900 assessments from independent providers that started last week. First 50 children were moved across. Those are the very long waiters, those waiting over 2 years to be assessed, largely for the neurodiversity pathway. That's starting now, so that's this year. That's in this year. The third part of the strategy is a bit like we talked about earlier. It's changing the way the medical model, particularly for neurodiversity, we're never, with the increase in demand nationwide, we are never going to be able to manage a consultant-led service to make those assessments. So through Neighbourhood Health for Children, we want to get early intervention largely into schools, because the biggest partner is schools in this, largely into schools, to prevent the need for an assessment, a diagnosis, to get children the access to the support they need in schools if they've got query neurodiversity. That has changed, you know, that this has changed radically since COVID, not just here, everywhere, and Neighbourhood Health for Children seems to be the way forward to support that. But our focus has got to be to get those children waiting over 2 years, get them a diagnosis if they need a diagnosis, and the treatment and support they need.
Thank you.
Thank you, Mary. Ellen, do you want to come in on this?
Yeah, I just wanted to acknowledge that obviously we're working really closely on this issue as well with ICB colleagues, and I'm really committed to moving it forward positively for the population. It's been interesting, just a sort of observation coming in new to the organisation, that we do run a different model in Herefordshire where we don't see the same waiting times, and actually many of the points that Mary has mentioned around working collaboratively with schools, it being a therapy-led model, we don't have a waiting time problem, we have a very different model. So I guess one of my points of curiosity was how we've come to be in quite a different place across the two. So I think we've got a really big opportunity to embed some of what has actually come from, you know, a really innovative clinician seizing a problem and taking it forward, often the way, isn't it? We just talked about the importance of some of the clinical leadership around stroke as well, supported with the right tools from us to wrap around that with the programme management and the right communication with the public and so on. But I think if we should recognise that across our 2 geographies, we've got a really different story, really different picture. So it shows us that that is achievable to have the right outcomes for our population.
That's really helpful, Ellen. Thank you. And Mary, I guess that comes from being provisioned by different providers originally, does it? Or is that just something that's developed locally?
I think it's more local development.
It's more local development. Yeah, we've had. I was just going to add to that. So yeah, we've had a really innovative person in the Herefordshire service who kind of has seen some of this coming and just got on. So it's how we enable her to have more reach across the whole piece of the across both counties, really, which is something I'm, you know, trying to enable, and we're working together on that. And Simon, Mary and I have had a number of conversations about how we can take that forward at pace. So I think there's some great learning there.
Yeah, excellent. No, it is important, isn't it, that we're, you know, it's the classic sort of ask it, to be fair, in any organisation, you know, get great innovation. How do you then scale that up and make sure that that becomes normalised across the patch? So you're obviously onto that, and it sounds like a really important opportunity. So that's great. Kath, I wondered if you want to say anything about. I can see that there have been improvements around the infection prevention control issues around C. diff. But I just wondered if you want to say anything about kind of how we feel we can sustain that.
Yes, thanks, Chair, and thanks for bringing me in on that. We've very much been working with the region on this, and like resetting where we were from an infection prevention and control perspective. And this has been very much joint with our chief nurses across this and deputy chief nurses across the system, and one of my public health registrars doing some work around a C. diff collaborative. So we've really focused down on the C. diff. And I'm hopeful that that trajectory is continuing to see a decline. There's quite a bit of work that's gone on, quite a bit of technical work, quite a bit of work around prescribing of a medicine called fidaxomicin, and thinking about how we have a shared understanding of where we're at. And also all our trusts have been assessed again, and sewing that into the pure basics of it. And I'm really pleased to see the improvements made at Wye Valley to the point where we're nearly on standardised. So they've got a revisit in the next couple of weeks, and I have absolute confidence that we will be seeing further improvement. And they had the revisit at Worcester Acute yesterday, which was much more positive as well. So we've seen really good improvements and really good engagement with the chief nurses across the system, and that's how we'll get sustainability with this, with sewing it into what we do and the fundamentals of care that we provide for our patients.
Thank you, Kath. So look forward to hearing sort of that formal feedback, I guess, you'll get from those visits, won't you? So thanks. So Mary, thank you for the report. We'll note that, and particularly the areas of quality and performance that have been highlighted. We move on then to paper or item 11, which is over to you, Mark, for financial plan and delivery.
Thank you very much, Chair. So two elements in the paper today, just to pull out for the board. One on where we are in relation to 25-26, and then just to touch on medium-term planning, which is gathering pace and momentum now. So if I start with 25-26, then the paper you've got today talks about the finance position at month 4. Since the paper was produced, we're now in receipt of month 5. So I'm just going to kind of give the board the latest financial information as at month 5 as we go through. So you'll see then at month 4, which was July, we were ahead of our phased plan by about £400,000. If you remember, our phased plan deficit for the first part of the year, reducing then in the second part of the year by that step up in efficiency. So we're slightly ahead of where we needed to be at month 4. This did continue within the month 5 position that we've seen. So month 5, we're now reporting that we're ahead of plan by £1 million at the month 5. It's fair to say it's predominantly all within Wye Valley NHS Trust, who were 300,000 ahead at month 4 and are now £1 million ahead at month 5. So really good news there. It is worth saying that position does take into account the deficit support monies, which we know we're recipients of. So we've got quarters 1 and quarter 2 agreed within that position. Very quickly on quarter 3. That position does include industrial action financial impact, which was one of the questions raised earlier. So the trusts have advised us that the costs that were incurred during that industrial action phase were £800,000. So quite a significant sum. Predominantly that was within the Worcestershire acute hospitals. So we're just trying to work through understanding what was the big driver behind that, but it was predominantly linked to additional staffing around bank and agency and provision that was put on there. So that was the cost associated with industrial action, and at the minute we're having to absorb those because there is no additional funding available to deal or mitigate those costs. Also then within this position is efficiency plans and our efficiency delivery, and as we know, we had a very ambitious and increased efficiency level, 133 million pounds for the year. So at month 4 we delivered 31 million, and at month 5 39 million, because as we know that efficiency plan steps up again predominantly Worcester acute as we go into the second part of the financial year. What we're seeing at the moment is that the overall month 5 position is £600,000 behind plan, behind where we expected to be at this point. However, when you break that down, Worcester acute hospitals are 1.9 million behind plan, but that is offset by the Health and Care Trust and Wye Valley Trust that are both ahead of plan at this point in the year. That's also coming through when you break down then what is recurrent and what is non-recurrent in terms of delivery. So the month 5 recurrent delivery is £1 million behind plan, and again when you drill down a little bit further, 1.7 million is at Worcestershire Acute Hospital. So again, offset by over delivery in the other trusts, and this time on the recurrent side, it's predominantly the Health and Care Trusts that are a bit further ahead in terms of the phase plan at this point of the year. We are continuing to push on the development of efficiency, because I would probably describe that as our biggest financial risk at the moment for the system. So month 5 development of the plans has continued to improve. So we've got £95 million now fully developed, or classed as fully developed, and that was compared to 88 million at month 4, which is what was included within the report. The other big area we spend a lot of time focusing on then is around bank and agency, and as you know, they're a big focus at the moment across the NHS. Agency remains ahead of plan, so month 4 2.6 million ahead of plan. So I mean by that, we've not used as much as we expected to use as part of that plan we set at the start of the year. But month 5 position is £4.2 million ahead of plan now. So again, we've seen a big step up in terms of the reduction in agency expenditure. Bank expenditure then is 2.2 million behind plan, but now at month 5 it's 2.6 million. So again, we're probably using a little bit more bank than we would be expecting to use. But the biggest area there where we're seeing variances is within Worcestershire Acute Hospital. So agency 3.2 million ahead, but bank's 1.9 million behind. And NHS England are wanting to scrutinise bank expenditure a little bit more within Worcestershire Acute, just to understand what some of the drivers are there and what the plan is going forwards. Across the ICS then, at month 5, we are still forecasting delivery of our financial plan. I'd probably flag though efficient delivery does remain our biggest risk. We see a step up from month 6 and a bigger step up than in month 7. Again, there's a smaller step up within Wye Valley, but a bigger step up within Worcestershire Acute. So we're spending a lot of time at the moment trying to get assurance. The plans are robust, and we'll start to see that expenditure reduction as we move into month 7, which is always going to be challenging given we'll be right into the winter period then at that point. If I specifically pick up on some of the ICB elements then, so previously we've talked about our revised approach around contracting, and Mary just referenced some of that as part of the spotlight we just did around elective and diagnostics. As expected, we have had some pushback to the change we've taken around a more targeted approach to contracting and where we need to buy activity. I am pleased to report though that we're only now down to 5 contracts to resolve. They're all NHS contracts with NHS trusts, and they're all for trusts outside of the Herefordshire and Worcestershire system. So all our independent sector contracts we've been able to come to a resolution on, and that's still in line with the approach that we've previously discussed with the board and we wanted to put in place. So that does give us some opportunity, as Mary talked about, then to look at where we need to target some elective recovery in some more challenged specialties as we move forward. So that's part of the next phase now. Whilst the ICB then is reporting break even at month 5, there are some areas of financial pressure which are emerging, not new, but are continued to emerge. One is around mental health, what we call Section 117 aftercare packages, where somebody's had an inpatient stay and then come out and got a package of care. We've seen a large growth, not so much in volume, but in the cost of those packages. So we're just trying to work through and understand that at the moment. And the other area where we are seeing a lot of growth is around adult ADHD. And again, we've seen a big increase in our monthly run rate. We were running around £300,000 a month at the start of the year. That's up now at month 5 to £900,000 a month. So a huge growth in activity there. So again, we're trying to do a little bit more work to understand that and look at how we can kind of bring that back in line with the financial plan and the activity targets we set at the start of the year. We have included capital within the report. Capital, whilst it's showing we're overspent, that's exactly where we intended to be at the start of the year. It was a very different approach this year where we were looking to get spend prioritised and in place much earlier. So month 4 showed we were 1.6 over plan, is back down to £1 million at month 5. So again, that's exactly where we needed to be. So those are the finance elements that I just wanted to pull out within the report. Just on to quickly touch on medium-term planning then. So as we know, the NHS now wants to move to a more longer-term planning approach from the annual planning cycle that we've been in for the last few years. This was referenced in the 10-year plan, and we've now had a planning framework released by NHS England that came out in August. It talks about 2 big phases they want to work through, and I've outlined those in the paper. It's also a slight change from the way we've done planning in the past. Medium-term planning development now is going to be required at both a trust level and an ICB level. So yes, we will probably look at the triangulation, but it does feel we're kind of going back to an ICB view and an individual trust view in that area. We're currently in phase 1, and work is well underway across a number of areas there. And as part of that, NHS England have now released a couple of bits that are helping us. One is around how we should calculate our underlying financial positions. So again, we're just working through that at the moment, and it's taking a different view as to what is classed as recurrent allocations and what is non-recurrent and what should be calculated there. And also we're having to do an exercise at the moment looking at block contract levels. So if you remember, post-COVID, the majority of contracts now have been block. There's a piece of work underway at the moment to try and, they call it deconstructing the block, to try and understand what's in there and what that means in terms of activity and price. So we're working through all of that at the moment. Supporting planning then, we haven't really stopped planning, but we've kind of enhanced now the internal meetings with trusts and within the ICB. And I know trusts are escalating their overall planning approach within their organisations and with their boards. There's a lot more to do on medium-term planning. Be a lot more that we need to bring back to the board. So expect me to be talking about this lots over the next 3 months, because the intention is to have all of this done before the end of December. So I really just wanted to put it onto the board's radar today, but we'll talk about it a lot more, particularly in development sessions, in terms of where we're at and what the strategic direction is looking like going forward. So I'm happy to stop there, Chair, and take any questions on anything within the paper or on month 5.
Thank you, Mark. So any comments or questions? David, please.
Thanks, Krishni. Thanks, Mark. That was really clear. Just taking us back to the 1-year planning, you mentioned that there are £95 million worth of efficiencies which are planned, which leaves about 38 million unplanned, which kind of seems to chime in with the high risk efficiencies there. Are plans being developed for those remaining high risk efficiencies? Because if not, obviously I think it's unlikely we'll achieve them without the plans being put together.
Absolutely. So when I talked about the 95 million, David, it was in relation to they're fully developed. So it's not that there's not schemes for the remainder of the efficiency that we need. It's that they're still in the development phase, i.e. they're not fully signed off in terms of the quality impact assessment or what needs to happen, specifically detailed. And likewise, there's an amount in opportunity still that we're working through, and trusts are working through with divisions and directorates in terms of how can we implement. As with all of this, I'm sure there'll still be some areas we need to focus on as we get into month 6 and month 7. And I know specifically within Worcestershire Acute, they've had a targeted number of sessions with directorates and the divisions, because that's the area at the moment in terms of the overall programme. I'd probably see a little bit more financial risk because of the step up. So we've put a lot more challenge in there, and I know their financial recovery board and their trust board are overseeing this and really looking at making sure they've got mitigations in place. So we will keep the board fully appraised of that, David.
Great, thanks, Mark.
Thank you. And I guess, you know, this is easy to say but hard to do, but in terms of medium-term planning, you know, there's something just about kind of what's our rolling efficiency stroke transformation program, because really kind of just, you know, in constantly trying to battle to deliver efficiencies in year, it is never gonna be the most sustainable approach. So I guess there's just something about making sure that all the brilliant work we're doing on building a sustainable future actually delivers quantifiable efficiencies that we can capture and reflect in a sort of rolling programme that then hopefully contributes ultimately to improved efficiency. So that's the theory anyway, and I would hope that that's what we'd be looking for, because I do think that's important as part of that medium term. Any other comments that anyone would like to make? I think there are just, it's probably good to recognise the progress on agency, which is important. I know the region continue to challenge us on bank, but it is important that we recognise the progress on agency as well. So thank you, Mark. I think you're highlighting for us that, you know, there are some positive things in there, like the sort of continued consolidation around confirmed efficiency programs, but obviously more work to do, and it's recognising that the risk increases around efficiency delivery in the second half of the year, doesn't it? And the report highlights that there's also then the, you know, as the months roll on, it's harder to have the impact that you need to. So obviously ongoing work on this, and I know our ICS Finance Committee and all colleagues will be focused on it. So thank you very much. Okay, we move on then to the final elements of our meeting today. We have the committee escalation and assurance report, followed by the board assurance framework. Hannah, I'll hand over to you to just comment on the first of those, item 12, and obviously invite any chairs of the committees to comment on anything that we perhaps haven't covered so far through the course of the meeting that might be in their committee reports. So Hannah, over to you.
Okay, thank you, Krishna. So unlike the last two reports, we haven't got any kind of generic committee updates. We have updated our terms of reference. We have done our committee effectiveness update. So this is really just an individual committee update. There's obviously been a lot of activity over the last 2 months. All committees have met and operated as expected. So yes, just really over to the chairs for anything they would like to pull out specifically.
So just invite chairs. If you'd like to come in, Rachel.
Yeah, just a quickie really, just to dovetail with what Mark has been saying. We're spending quite a bit of time on, you know, splitting, I think I've said it before, splitting the committee between in-year delivery, but also how we link into the BSF and developing the strategic framework around finance to link in to all the planning work. So that kind of dovetails in with what Mark's saying, and just to say that we'll, you know, obviously, as Mark said, we'll be spending quite a bit of time on that over the next 2 or 3 months, but we've all laid quite a good some, you know, quite a good grounding really over previous months to enable us to do that. So I just wanted to say that we are kind of dovetailing, and that's the focus we'll be having.
Lovely, thank you, Rachel. David?
Just to say that Mary's report brings out everything we need to bring out on QRD, so nothing extra to add for that. Thank you.
Thanks, David. Okay, I'll take it that other colleagues don't have anything they particularly wanted to add. I just wanted to, I think I picked up from one of the reports, did I, around the BCG vaccination? Did I pick that up in one of the committee reports? It might well have been the QRD. I'm just quickly flicking through now to see if I can see it anywhere. It was the immunisations around BCG vaccinations, wasn't it? And I think this came out of the QSRM as well. So I don't know if Will, you wanted to comment on that.
Yeah, it's been flagged as we're sort of falling behind on the BCG vaccination for at-risk children. It's been flagged both at the vaccination programme board and through LMNS. There is an action plan in place to try and, well, to rectify it, and we will have quite a lot of oversight on that going forwards, both through both the programme boards, because it actually relates to both.
Thank you, Will. That's helpful. I thought it'd be useful to comment on it, as it had come out of our QSRM previously, our quarterly system review meeting. It was alerted to us at that point. So thank you. So we note that report. I don't think there was anything, Hannah, that we needed to approve. So it's just a noting of those updates. So thank you for that. And then to the item 13, which is the board assurance framework, please, Hannah.
Okay, thank you. So as you all know, the board assurance framework tracks progress against the ICB objectives and priorities and shows where we are compared to the target position that we set out at the start of the year. That's shown hopefully quite well on page 2, where you can see the overview of all our priorities, their current assurance and their target assurance. And given that we are now almost halfway through the business year, it's quite pleasing really that we can report progress in a number of areas. And this is shown on pages 3 to 5 of the report and relates to individual success measures. So I think it's really positive that these kind of increases in assurance cover 3 different objectives with a fairly broad remit across the ICB operation rather than relating to just 1 or 2 specific areas. And then page 6 summarises the current areas of concern. Actually, having looked through them, we've talked about all of them at some point in the meeting today. And then finally, page 7 sets out the changes to ICB risk scores, which were made since the last report, 3 of which are risk closures. And 1 is a temporary increase, which now feels a little bit out of date relating to the industrial action. But obviously, due to the reporting timescale, this is only just coming here as a risk increase. And again, I know we talked about the industrial action earlier in this meeting. So I'll pause here, but I'm happy to pick up on any questions, and I'm sure my colleagues as well will be happy to cover any specific areas that anybody would like to ask about.
So any comments then or questions relating to the BAF? Vicky, please.
Thank you. I think just to reinforce what you were saying, Hannah, because I think that, you know, the midpoint through the year almost and showing those shifts in assurance is really positive for us as a board to see that, and on the specific actions that the change in assurance has been provided. So, you know, thanks to everybody for that.
Thank you. Yes, because you know, it is important, isn't it, to see the movement, because otherwise it does feel like all that work is not really mitigating the risk. So it's really helpful to see that assurance. I think again I picked up from the committee escalation report, Hannah, a reference to CSU closure impact. And I know that that was mentioned in relation to, I think, the ICB's corporate risk register. So I don't know whether we want to say anything about that. I know that's a sort of transition type issue, but perhaps you can say a few words about that.
No, absolutely. There is a national, regional and a local group all looking at the risks and plans associated with CSU closure. I sit on the regional group on behalf of West Midlands, and so I'm relatively well informed. So at the moment, I mean, it's fair to say there's a bit of a I suppose, gap in transitional planning in terms of CSU closure from a national perspective, but locally and regionally what we have done is through the work we're doing on shared services, where essentially the three ICB clusters in West Midlands are getting together, identifying services that we can kind of work at scale, and that obviously links to the services that the CSU provide at the moment. So as part of that work, we have identified services we want to transfer in the first phase, hopefully in the next 12 months or so, and we are talking to the CSU directly about the transition timescale and mitigating risk, and that's actually really helpful, because it means that any sort of skilled staff in particular areas of where we would struggle to recruit, or where we would struggle to kind of find our own staff, we know that this will be quite well mitigated. So we are looking at this piece of work through both the operational executive committee, but also the transitional committee that we have set up jointly with Coventry and Warwickshire. So perhaps we can do a more of a detailed update at the next board if that's of interest, just generally in terms of shared services and the CSU work, because it is getting quite topical and will have an impact on our transition overall and on our staff. Or perhaps we can cover it in Simon's report in more detail next time.
Yeah, I think that might be helpful, Hannah, because I think, it is important to recognise that we need to maintain, given, I think, a couple of comments that people have made, there's what we do want to do is maintain the progress, and it is really important that the foundations that have been laid by all the good work across the system by partners collectively is not jeopardized, and so really managing these transitions safely and keeping what's good and improving what we can remains really important. So perhaps some reference to it through Simon's report might be helpful. Rachel?
Sorry, thank you for raising that, because we did talk about that at the QRD, and I think just to build on that, they're often people who've got fairly, skills that are difficult to recruit to, and for example, data analysts and BI kind of people. So I think I'm really welcoming the work that you're doing, Hannah, because I think it's really important to underpin all the strategic work that we're doing at the moment and the delivery work.
Yeah, absolutely, and key to I think maintaining our ability to do what's being asked of us as well. So it's really important that we retain what we need to enable that. Well, thank you very much, everybody. We have run over time, but I felt many of the discussions we were having were, well, time on the agenda, but not in our slot. So I sort of take that as reasonable, but I did think the discussions we were having were actually really important, and therefore important to sort of focus on some of those areas that we wanted to and make sure we covered adequately. So just really want to thank everyone for their contributions, also for the work on papers and assurance, and also thank Jane again. We've enjoyed your contributions again today, Jane, and we're going to miss you, I think, because you've made you're always a big contributor to the board, and that's always welcome, because this is ultimately a partnership, and all our voices in how we do things well and differently matter. So thanks again, Jane, and I wish you all the best in your whatever you go on to do, retirement or otherwise. Some of us might be a little bit jealous as well, but there you go. So thanks, everybody. Have a great day, and our next meeting is Wednesday, 19th of November, and obviously we'll see board colleagues at a development session in October as well. Thanks very much. Bye.